Well, hello and a very good morning to all our panelists and our listeners for tuning in so early this morning. I'm Pui Li, an infectious disease lecturer and physician at University Malaya, and your moderator for this morning's breakfast at UMHealth Forum, entitled Balancing Care and Confidentiality in HIV. So today's forum is actually held in conjunction with World AIDS Day, which is held on the 1st of December every year. And this year's theme is Overcoming Disruption, Transforming the AIDS Response, in light of the severe disruption of life-saving services and many communities left vulnerable. So people living with HIV actually entrust us with their stories, their vulnerabilities, and their hope for healing. And it's our responsibility to provide care that is clinically sound and a place where they can be emotionally safe. So today we'll be exploring how to balance compassionate care with confidentiality with our esteemed panelists. So let me introduce each of them. And also feel free to say hi in the chat. So firstly, Dr. Raja Iskandar Azwa is an associate professor in infectious diseases at University Malaya, our clinical lead for HIV services at University Malaya Medical Center, and the president of the Malaysian AIDS Council. So welcome, Prof. Iskandar.
Thank you, and good morning, everyone.
Okay, and next we have Dr. Phang Chang, also known as Alex, who is the head of the Medical Research Ethics Unit at University Malaya Medical Center, as well as a senior lecturer in the Department of Pathology at University Malaya. So welcome, Alex.
Thank you. Hi, good morning, everyone.
And last but not least, we have Ms. Samantha Chong, who is a former prosecutor and established human rights lawyer in Malaysia. She's also known for her work in abolishing the mandatory death penalty, drug policy reform, criminal justice reform, and medical cannabis. She's currently an advocate and solicitor at the High Court of Malaya. So welcome, Samantha.
Hello, everyone. Thanks for having me.
All right. So on that note, we will be starting off our forum. And I thought just to kind of warm us up into the topic, perhaps each of you can share a little bit about what confidentiality in HIV care means to you in your daily work and why does it matter? So perhaps I'll start with Iskandar, then Alex, and then Samantha. Iskandar, would you like to go first?
Yeah, thanks very much, Puli. I think this is, thank you for spearheading this. This is a very important discussion. And because it's an ethical talk, I think confidentiality is the need to keep the HIV status of a patient who's diagnosed with HIV secret, and it's not just an ethical, but it's also a legal obligation. It just doesn't apply to the patient's HIV status, but it also extends to their personal data, and really disclosure is not allowed ethically or legally unless the patient gives specific informed consent under very specific circumstances. So I mean, you can understand why confidentiality is important. It protects a person's HIV status. HIV is a highly stigmatized disease, and I think remains probably one of the most stigmatized disease around still. Very much, you can compare it to mental health as well, but, comparably, I think it still remains much more stigmatized. The fear of disclosure, if you lose that rapport between doctor and patient, risks the patient dropping out of care, and it discourages people from coming forward to get tested, to access care and retain care. And most importantly, I think that respect of confidentiality is so important to build that trust between patients and healthcare providers. And as I mentioned, and this because this is an ethical talk, it's also a legal and ethical requirement. And of course, it supports what we want patients to do. We want patients to take their treatment. We want patients to come in and get diagnosed at an earlier stage. We want them to be virally suppressed. They take their medication and they are undetectable, so they don't pass the HIV on. And at a larger population level, it reduces HIV transmission in the larger population.
Thanks, Iskandar. I'm really glad that you mentioned stigma right at the outset. I think often this is the main driver of why confidentiality becomes such a big issue in HIV. Thank you. Alex, do you want to share your thoughts about what
Yeah,
HIV care means?
yes, I would like to echo what Iskandar mentioned just now. So, yeah, I feel myself wearing a few hats in UN and also UMMC, but at the core of it, I see confidentiality as a foundation of trust. So, if people living with HIV do not trust us as a clinicians, as the healthcare workers to protect their information, so yeah, probably they may delay testing. They try to avoid follow up or just not to participate in any research. Yeah, that could eventually benefit this community and in large, I think their family as well. So I think the consequences is not just about emotional, talking about confidentiality, but I think eventually uh, uh, it can actually affect the treatment outcome, their family relationship and all that. Yeah. So, but however, I think, I mean, from the perspective of ethics committee, confidentiality does not mean that information never move. It's just that we need to, all the healthcare team, people like, for example, lab staff, nurse, pharmacists, not only the doctors lah, even the administrators also need to ensure that, we share the information for providing good care. Yeah. So for me, the ethical question is always who generally needs to know uh, uh, this information and for what purpose and what is the minimum detail required for that. Yeah.
Thanks, Alex. I mean, I
Yeah.
think it's certainly becoming clearer that when confidentiality is at stake, then the care of someone living with HIV and their health becomes severely
Mm-mm.
compromised. And, I like what you're saying in terms of the sense as, who needs to know and why do they need to know? And I think that's where the balance comes in. So maybe I'll move to Samantha to share her thoughts as well.
So, for me, confidentiality is a fundamental human right. It touches the very fundamental of human dignity, where human rights are standing upon. Because recently we see cases whereby people are arrested. They were questioned about the HIV status. You know, that in circumstances they were made public, and you can see that people who get arrested, they are very worried to get their status disclosed, and therefore they might be, they will be denied their medications, ART, ARV. So this is totally against human rights. And if you see universal declarations of human rights say that all individuals is worth of respect and shall not be humiliated, insulted, or subject to degrading treatments. So if we do not have confidentiality, do not have the trust, I think this is totally against human rights. Everybody should be protected for equality and non-discriminations. And I would say that if a person does not have the or right to see, basically this is making them having a degrading subhuman treatments. People are afraid to get tested because sometimes they suspect they have certain issues, but because of this stigma and lack of action to delay testing, which could make things even worse. So I would say that confidentiality when it comes to HIV status is something that is not aware by many legal practitioners or law enforcement agency. They think if you have HIV, then you're supposed to be doomed because it's your fault, you're immoral. I think we need this. When are not aware of you equal to you. I wasn't aware until a few years back. So I think we definitely need to do more when it comes to confidentiality. And I've seen too many cases, and I think we need to change the law to make it very clear that confidentiality, especially when it comes to HIV status, must be made expressly prohibited. So that's my take on confidentiality. Thanks.
Thanks, Samantha. I mean, I think it's so important to highlight right from the outset that confidentiality is a human right. And by violating these things, we violate their dignity and, their rights as a human being to be treated equally, and have access to healthcare and anything really as anyone else. So thank you so much for sharing your perspectives on confidentiality in HIV care. So I'm just going to move on to talk about a little bit about disclosure. I know Iskandar has spoken about it and touched on it in his introduction. But people living with HIV are often very concerned about disclosure of their status, whether it's to their partner, their family, or even to their employers when they are diagnosed, and what their rights might be. I mean, we've all heard stories of PKD banging down on people's doors. So maybe Iskandar, you can start us off. As a clinician, could you share a little bit about why this would be the case? Where their fears stem from, and in what circumstances are disclosure really necessary and unnecessary?
So I think as infectious disease physicians treating people with living with HIV, I think we're very good at putting ourselves in the positions of our patients. I mean, as mentioned, I mean, HIV has been stigmatized for so long, and the response from when it first appeared in the 1980s to now it still remains the biggest barrier to HIV care. So things have improved, certainly, but things still need to considerably improve, because it's now spanned over 30 years, and the root of I guess all this is it lies is, as Samantha touched on it, immorality and people judging other people for how they should act and behave. I think when somebody gets diagnosed with HIV, they themselves, I think we need to remind them ourselves as healthcare professionals dealing with people living with HIV, they have already punished themselves before they've seen us, and they continue to judge themselves. We do not need other people, including healthcare professionals. Healthcare professionals are the worst, unfortunately, when it comes to judging other people living with HIV. And I think, and as a Muslim, we're supposed to treat people irrespective of health, economic status, morality, and everything. So I think there's also a religious component that certainly comes to it. So I always put myself in the patient situation. So when unfortunately, we're required by law to sort of disclose if they certainly if they see us within a public healthcare setting and also a private healthcare setting, and we're required to notify because it's an infectious disease, and so we fill the notification form that's required, and it is reported by name and IC. And often we spend a lot of time reassuring patients that of that process, but it is limited largely for statistical purposes, but it is still required. It still requires notification by those measures. I think, and so that can sometimes be a problem, and which is why some people access private healthcare, because, in all honesty, in private healthcare, people are less likely to notify HIV status. So I think that was your first question. What was your second question? Sorry.
I guess I wanted to know, in what circumstances is disclosure necessary and unnecessary? Are there instances where you would maybe encourage your a person living with HIV to maybe disclose it to their family or their friends?
Yeah. So ultimately, we want patient to continue to access care. So certainly, if it's a long-term partner, a lifetime partner, husband or wife, we certainly encourage disclosure. It's always nice to be able to give patients time and not force them, although the notification, sort of enforces us that we have to disclose within a certain period of time. But often patients just require time to disclose. Family members are encouraged only because any support network that can provide support through this process and encourage them to navigate our system and continue to access care would be encouraged. So that would be the reason to disclose to a family member or a friend, a good friend. Employers, you do not, in most settings, we would not encourage that at all, because there is no need to really disclose to an employer at all. Where disclosure might be certainly necessary is in healthcare settings, especially when you're treating patients. But that environment is changing with U equals U, and I will talk more about a bit about that later. And certainly with a potential risk to long-term partner. And of course, unfortunately, and Malaysian Health Council continues to work with this, is for insurance and certainly legal insurance purposes, you'd have to disclose. Where you may not need to disclose is if you have casual contacts, schools, and in most public settings as such.
Thank you. I mean, I think it's important to know that actually the internalized stigma that someone living with HIV experiences is actually really, really strong. And oftentimes, sometimes encouraging them to disclose it to their family members, or at least someone that they trust, can actually help them through that process and kind of have keep them accountable to continue to access healthcare, to make sure that they stay on their medications. So thank you for sharing that, Iskandar. Samantha, can I come to you? So we've talked a lot about disclosure. Are there laws that cover the disclosure of HIV status, either in healthcare or in employment?
Sorry, I'm trying to unmute. Yes, if you look at employment, the laws when it comes to privacy. So the first one will be the Personal Data Protection Act. So medical status, your medical info records are considered sensitive personal data. So to disclose it, the employers will need your express consent, often written, to disclose it. But this is normally not the case, because a lot of people doesn't know where to complain. But it is actually a crime to disclose sensitive data without consent. So this is one. And under the Employment Act, which regulate, can you hear me? So under the Employment Act, there is there's a no discrimination provision where the Director General can inquire into any incidents of discrimination at workplace. So if a person is dismissed because of HIV status, and these workers can actually file a complaint with the DGs. As far as Industry Relation Act 1967, so Section 20 provides an avenue for unfair dismissal for employees, or if these employees are made to resign. For example, he's being excluded. They no longer invite him for meetings. His work was taken off, from him. He's demoted. If he has forced to resign, he can actually file a complaint and claim under constructive dismissal. And so ultimately, I mean, the highest law in the country will be the Federal Constitution. The Article 8 of the Federal Constitution say that, there's guarantee equality before the law, that no person everybody is given equal protection of the law. So it also prohibits discriminations based on religion, race, place of birth, gender, unless being permitted by the Constitution. There are certain positive discriminations in the law. So, and I think although like confidentiality and privacy laws are sometimes not expressly spelled in the law, but I feel like in the future, or maybe now, we can start the class actions to make the courts to acknowledge that privacy, confidentiality is the constitutional rights. So when it comes back to your question about employment law, there's no strict express provisions on HIV status confidentiality, or whether they can be dismissed on based on their status. There's no express provision, but there's a code of practice on HIV and AIDS at the workplace. If you go to Australia Occupational Safety website, they said you shouldn't make them to go through military testing, dismiss on that. But this code of practice remain as a code of practice. It is not the law. So some companies has adopted this code of practice, but it is still not good enough. So I still think that first, we need to challenge the law. We need to acknowledge that confidentiality, privacy is our constitutional rights, although it is not expressly spelled out about confidentiality of HIV. Second one is we need an express law to say that mandatory testing shall not be adopted, especially in workplace where it is not of a concern. I mean, in medical setting, we can understand because of security or safety reasons. But if it's just a banking job, it's just a clerk in the legal firms, being HIV positive, living with HIV or not, I don't think it will affect the job or the effectiveness in the workplace. So it shouldn't be made mandatory. There should be express legal provisions to stop this. Because only the change of law can help to destigmatize, myth and misconception around HIV. Thank you.
Samantha, can I just ask you to clarify what's the difference between code of practice and law?
So a law, it means that the companies, individuals, governments need to follow. A code of practice is just like administrations. Well, it's encourageable to follow. It can be the best practice, but it is not a legal requirement. Unless the company have adopted this into their employee manual or something, and that will make, there's some space for argument. If they don't refer to this, it's just administration. It is persuasive, but binding. So companies can just langgar this. They can just don't follow this code of practice, and they don't commit. They don't commit a crime. They don't do a legal wrong. So bring code of and law. So there's no consequences basically.
That's very sad. But maybe, can I ask, maybe either to you or Iskandar, are there avenues where someone that feels that they've been dismissed inappropriately due to their HIV status? Like, what can they do?
Can I take this? So if they're being dismissed, they can file a case in industry courts. But I think there's certain days, I think it's 16 days from the dismissal, they need to file a case in the industry courts because they cannot be dismissed just because, of their status. But most cases we've seen is that they sign a declaration before the employments, that they do not have certain medical conditions and such. So companies will use that to say that, come on, you have violated this clause, therefore we have to dismiss you. But to dismiss you, the person, it cannot just give a letter like that. There should be show cause, there should be proper process to follow. If not, that can be considered unfair dismissal, even though that this person has not told the truth, when about the status. But of course, in the long run, I feel like we should challenge these declarations that you need to sign before you enroll into the employment. I think we should challenge this because as long as the courts never.
Sorry, Samantha. I think it's frozen.
So while we unfreeze Samantha, Samantha, have you been unfrozen? Okay, she's
No,
still.
not yet.
Can I just add
Yes.
over a minute initiatives by Malaysian AIDS Council? So we do provide legal aid, and the first point of contact would be what we call the Malaysian AIDS Council Care, MAC Care, which really is an online communication channel for communities at risk of HIV or living with HIV to really report any acts of discrimination, whether in employment or otherwise, and they will be, and a specific advocacy worker will work with that person, and legal aid will be provided if needed. So most of what we see discrimination acts have largely been, unfortunately, in public universities. So this is relevant, as well as in employment practices which are outdated, and also from the changing the law practice as well. Malaysian AIDS Foundation is also working with the Human Resources Ministry to amend the Employment Act and the Industrial Relations Act, really to protect people from workplace discrimination. So really going to the higher level. But it takes time, of course, and this process has been really over the past year and a half.
It's so encouraging to hear that these initiatives and these processes are ongoing. Thank you so much. Samantha, we lost you for a bit there just now. I didn't know if you wanted to kind of summarize.
I don't know where I was just now when I was cut off.
Ah, okay, all right. Perhaps you can come back to that later.
All right.
We will go to Alex. So, Alex, as you're the head of medical research ethics, like what aspects of disclosure and confidentiality do you look at whenever research involves vulnerable communities, like people living with HIV?
Yeah, I think that's a very big question for us from ethics committee. So generally, when we review research involving people living with HIV, so I think we have many this type of studies ongoing in UMMC. So there are quite a few things that we pay very close attention to how information about their status being disclosed, shared, and yeah. So at every single stage of the study, we want to say uh, we want to see how the information has been safeguarded. So first, I think similarly to the legal aspect, we also look into the consent process. So essentially, we really want to know whether the participants clearly understand who will see their information and how their HIV status will be recorded in the all the data information sheet, and whether it will ever be shared beyond the immediate study team in or UMMC. So we want the consent form and also the conversation to spelled out explicitly in simple language, because all of these people, they are not medical professionals. So we want to make sure that it is the language that they comprehend. Um, so secondly, we also will examine how much identifiable information that the researcher really needs. Okay, so very often we see studies actually collect their names, IC numbers, even their addresses, and very detailed histories by default. Yeah, so I mean, for ethics review, we usually ask like can you answer your research question with less information? So it's like, can you get minimal identifiable information to answer your research question? So I think that's a very important thing that we are thinking a lot. So if the answer is yes, then we will insist on minimizing identifiers, and we will insist the researcher to use the codes or pseudonyms. And usually we will ask the researcher to store the coded information separately with the raw data, with all the identifiable information, so that when there's a breach of all this information, at least it's not this information is not together. So that's the advice we would give to the researcher. So and number three is that we will also consider the real world consequences of breach. So this is something that we always think about, because usually people might think this is just remain as a research, but for people living with HIV, uh, usually it involves the key populations, like men who have sex with men, sex workers, and sometimes we deal with people who use drugs. So eventually, all these unintended disclosure can lead to discrimination, and also like loss of employment. For example, I think recently um, the cases that going around, yeah. So all these legal problems, and because of this potential harm is so serious, so therefore I think the standard of protection of this rich participant has to be higher than other populations. And finally, we also look at that's a very important part when we look at the secondary use and data sharing, especially the cross-border one, because our researchers have a lot of all these international collaborative projects. So if the researchers want to share HIV data with their collaborators or store it in the large international database, so we usually will ask if is this covered in the original consent? Is the participant actually aware of this? Or yeah, and also we want to know whether, the partner side, whether they have clear governance structures. Okay, so do they have the data transfer agreements? And we will look into all these documents. And yeah, so, and also I think we want to know if there's any safeguards against re-identifications. So yeah, so those are not only the technical details for basic data management plan, but I think the central ethical issues here is to determine whether people can safely contribute to research without increasing their vulnerability, the more and more layer of vulnerability. Yeah, so that's my take.
Thanks, Alex. I think that's a very pertinent reminder because I think as researchers, we're always wanting to get more data and more data and more data for fear of, not being able to trace back something and whatnot. And it's so important to remember that this is a vulnerable population and we need to safeguard their information. So we should really only be using and taking what is absolutely necessary for our research.
Yeah,
Thank you.
exactly. Mm-mm.
Yeah, so I'm going to shift gears a little bit. So for the next 20 minutes or so, we're just going to cover a few scenarios, 2 or 3 scenarios, if time permits, to try to really just consolidate our thoughts on confidentiality and care. So I always think that University Malaya is a very interesting entity because it has education, research, and healthcare all rolled into one. So I'm just going to start us off with our first scenario, which is about university applications, which I think that Samantha has also touched on at one point. So a student is applying to enter university to study at University Malaya. He has been asked to do a blood test to check for blood-borne viruses, such as hepatitis B, C, and HIV. He is aware that he has HIV. How should he proceed? So perhaps I'll get Samantha to start us off. So from a legal standpoint, what are his rights pertaining to this blood test? Can he refuse it? Does he have to declare his status?
Okay, if you look at the University and College Act, the universities have rights to do certain conditions for students' admissions. And so I remember when I got into University of Malaya, I was not asked to do HIV testing, if I remember correctly. But the question is, when the university put out an admissions requirement, it is always subject to be tested at the courts whether such requirement is actually reasonable or legal. So my quick research shows that a foreign university, they have to do infectious diseases testing, I think, to prevent the spread of certain diseases. But I don't think it should be legal to make it mandatory for students to go through HIV testing, especially when they are not enrolled into certain courses like medical or nursing, which might expose them to certain risks. And of course, the ideal case will be they should be able to refuse, but in practice, people will just take it. Most probably they don't know they have it. So in this case, if he's made to undergo HIV testing, then and the status come up positive, and if it's dismissed, I think there's a good case to file against discriminations, because nobody should be subject to such discriminatory practice when HIV is used as sole conditions that this person shall not be enrolled into the program. And next, we have to ask, what is the data protections and privacy protection by the university? Because with great power come great responsibilities. So if they are given the rights to test, then they must have the responsibility and the duty to protect confidentialities and to provide options for these persons to go through counselings or any other intervention. It cannot just be a testing to find out whether this person is positive or not without any other or care systems. So I think that it is important to emphasize the data protections mechanism. Yeah, thank you.
Thank you. Iskandar, do you have anything to add to that?
Yeah, just very quickly, I think overall there's uniform, transparent HIV policy for all public universities in Malaysia. And so I think it's really at the discretion of the university. I'm talking about public universities to test, and they may have specific reasons or rationale for testing, which never seems very sensible anyways, because mandatory HIV testing should not really be imposed unless the person involved is at risk as such. So I think first of all that is a bigger issue, and I think this issue has been highlighted recently because of a lot of media coverage on the increase in the number of HIV cases in universities. They're small, but there's been an increase over the years in universities. So there's been a bit more of a spotlight on this. I think personally, and from maybe representing civil society and Malaysian AIDS Council, I'm, and like Samantha mentioned, we're generally against mandatory HIV testing because the infrastructure as such does not exist for support of the person once they get diagnosed HIV positive or if they disclose. So in terms of confidentiality, counseling, post-testing, and stigma ultimately. And it really doesn't determine whether the patient's HIV positive. Often, if the patient's young, they're still, and not in advanced HIV disease, they're still fit to continue. And so really it should be about whether the patient is medically fit to continue. HIV, a lot of people with HIV are clearly productive to society. So I think as long as so that's my first point, and that's more a general point about testing within universities. The second one, private universities have a more structured approach. Interestingly, if they're subjected to testing, they are allowed to continue. And so I think when you subject somebody to testing in a public university, there needs to be a clear understanding of what happens if the person tests HIV positive, and it should not be discriminatory. And as Samantha said, I think in this case scenario, if he's going to be subjected anyways because it is the policy of that department in that particular university, then I would encourage disclosure beforehand because he's going to be tested. I mean, he can go ahead and test, but if he found positive, but I would want to, I would advise him to. I would want to know what is in place to support him. And I think as ID physicians, there's lots that we can do to then provide support for him and make people understand what a positive HIV diagnosis means, because a lot of people are still sort of stuck in the Stone Ages and feel that HIV is treatable, but everybody with HIV will there's still a belief that everybody with HIV will pass on the HIV disease. Well, that is absolutely untrue, because if they're on treatment, they will not pass their disease if their viral load is undetectable, and it should not really affect their ability to enter university and otherwise. That should be very clear. I think also does need to work on a policy, and something that we should, assist the university to work on this, because I don't think there is a standard policy, but in favor of the person living with HIV.
Thanks, Iskandar. Because U equals to U has been brought up a couple of times, I was wondering whether you could just kind of like let the audience know what U equals to U is.
Yeah, okay. Thank you very much for that. So, I mean, U equals to U simply means undetectable equals to untransmittable. It largely applies to sexual transmission of HIV, and it's supported by robust data of one randomized controlled trial and 3 observational studies of 150,000 serodiscordant couples where one partner is HIV positive, the other partner is HIV negative. Now, Alex could question the ethics behind how this managed to go through, but it was an important question for people who treated people living with HIV to explain the risks of transmission to their patients. And so the results unanimously found that amongst 150,000 serodiscordant couples, provided that the patient had a viral load of less than 200 copies per mil, so by definition undetectable, there was zero transmitted cases from that HIV positive partner. There were some cases that became HIV positive, but because through further testing, phylogenetic analysis, they managed to point out that discover that the patient got HIV from outside that relationship. But for purposes from within that relationship, there were no linked transmissions to the positive partner. Now, this is 150,000 couples. So, I think that sort of seals that. The risk of transmission is not just negligible, it is zero. It largely applies to sexual transmission. Some people might question whether this applies to blood-borne transmission, but it can largely be extrapolated to occupational transmission and blood-borne transmission in the setting where the viral load is undetectable. So there is no reason to discriminate people for living with HIV. The point is to diagnose them, get them into care, and get them started on treatment as fast as possible and get their viral load undetectable for a public health initiative and reason.
Thanks, Iskandar. And Samantha, I really, really love what you said about, with great power comes great responsibility, right? So if universities are, making it mandatory for people to test for bloodborne viruses, that it's also their responsibility to safeguard these people and ensure that if they're found to have HIV, that they are linked to care and have good access to treatment. So I think that's so important. And Iskandar, you touched on the policies as well. And I think there's room to work on this so that even though the mandatory testing may be there, that people undergoing it feel safe, that whatever the outcome is, the outcome will not be discrimination, but the outcome would be access to healthcare and treatment.
Absolutely.
Right. So, and furthermore, about like 40% of our new HIV diagnoses are among people at the age of 20 to 30, right? And these are university student age. So I'm going to shift gears to our second scenario, which focuses a little bit more on research. So a researcher in University Malaya Medical Center would like to conduct research in individuals living with HIV who use drugs for recreational purposes. So Alex, I'll direct the first question to you. As certain drugs are not legal according to Malaysian law, how would you navigate the ethical issues for the research project to protect the research participants?
Yeah, that's a very good question. So I think the moment when you put HIV together with even it is recreational drug use, you're actually dealing with a highly sensitive and potentially risky context, regardless whether the particular substance is technically legal or illegal. So yeah, and also there's a stigma around both HIV and drug use. So and in some cases, there might be some real legal risk. So for me, I think the first step is a careful risk assessment that I think the researchers should include the voices of the community. So yeah, so first is whether there's a necessary to conduct this study, where is it really relevant to them? So I would want the researcher to consult the community groups or peer educators who work with the people living with HIV and also who use drugs. So they can actually help us to understand better what kinds of questions that they feel safe and what could be more, self incriminating, and what might be, exposing people to harassment if the information is leaked. So on the study design side, we can actually protect the participants by collecting only the data that is truly necessary, as I mentioned just now, and also describe it in a way that to reduce the legal risk. So for example, instead of asking every single or very specific combinations of drugs, locations, or even the dealers who provide the drugs, so we might group substances into categories, or even more focus on the patterns of use and access to the service, for example. So we also may need to separate the direct identifiers from the main data set, as I mentioned as well. So using all the codes, and to store the data securely and separately. So as for the consent form, I think again, this should be very explicit with the information that comprehend by the participants. Yeah. And finally, what I actually concerned about is the training of the research team, which is very, very crucial, especially it's very fluid nowadays. The research teams, people come and go. So I think to ensure the consistent training of the research team is very crucial. So because I think we have very nice written SOP, but I think the research team who handle this kind of participants must understand the stigma. They should know how to avoid judgmental language, and sometimes uh, also knowing how to handle any accidental disclosure or request for information from the parties, like how do they handle those things. Yeah, so the aim is not just only to get the data for their study, but to also conduct the research in a way that does not further increase the vulnerability of the people that already carry multiple layers of risk. Yeah, so that's my thought.
Thanks, Alex. I really like the mention about community advisory boards. I was wondering whether you could just elaborate a little bit more about community advisory boards, because I think they're becoming more and more essential in research with vulnerable communities.
Yeah, I think it's not only specific for this HIV study, but I think nowadays it's getting more and more that we want our researcher not just working as scholarly, but also going outside uh, for all this public engagement, talk to the community. So what is necessary? Because eventually we want the study to create some kind of societal benefits to the community. So therefore, we actually have this. I'm not sure whether for Iskandar part do you have the community advisory board, but I think for uh, our clinical trial, I think recently we have this initiative to establish the CAB. So where we will invite not only the experts working in the field, but I think we have the public representative, we have the legal people, different stakeholders in that board to advise the researcher what is the requirement when you deal with this community. How do you go about this? How do you navigate, especially dealing with this highly sensitive population? So I think that may actually create more meaningful kind of research. Because research is all about the activities, right? So we want to know how exactly researcher dealing with people without disrupting their daily life and all that. So I think this board actually play very important role in providing those pertinent advice to the research team. Yeah.
Thank you. And as you mentioned, also the importance of training your research staff. I think often we hire and then we forget to train, even to use non-discriminatory language with our participants. So thank you for that. Samantha, out of curiosity, has there been any unintentional data breach of participant data where participants have been prosecuted? Are you able to share any of that? Oh, I think she's dropped off the call.
Good.
Okay. No, maybe never mind. I'll get Iskandar to answer the next question, which would be, would you be able to share some of your challenges that you encounter when you're conducting research in these populations with a focus on confidentiality and disclosure?
Yeah, sure. Thanks for the question. I just wanted to first of all add to Alex's Because like you, I think these community the community advisory boards are so important, and they're really the standard of care now with a lot of HIV research. I'd like to think that the HIV field started it, and it's generally moving outside. But I think what we often do wrong is just involve certain token community members um, at the middle stage of the research rather at the beginning of the research. So really, it should be right from the beginning, from the design, the implementation of research, and then to ensure that the community is regularly involved with updates of the research as well as dissemination of findings. And they shouldn't just be a token, but an essential member of the HIV research. And they should be remunerated as well for that. So, I mean, that's been the standard of care. And so very highly respected member of the HIV research team. And of course, people do it differently. Some people do it better. Some people don't do it so well. But I just wanted to echo that as well. With respect to the question, some of the question regarding challenges, I think Alex covered the sort of intersectional stigma around being, from a person at risk or living with HIV, and then the intersectional stigma around drug use. But I think what patients are concerned are mainly around also maintaining anonymity, and also Alex touched on this as well, and especially around, in my experience, mHealth applications and particularly the rise of AI, how data is going to be stored and handled, the importance of data encryption, ways to de-identify patients, and also to reiterate training for research staff on real and confidentiality policies. And really address what potential harms of accidental disclosure are. And I think because we're dealing with a vulnerable population, often HIV research or research involving persons at risk or living with HIV are really go more through they go through ethical scrutiny more than maybe other subjects in terms of their confidentiality protocols, plans to mitigate risk, procedures for handling disclosures of harm. But they're important to maintain the safety of patients. So maybe those are just a couple of points I wanted to add.
Thanks, Iskandar. We have 5 minutes or so left on the clock. We do have one question in the chat box, so I think maybe we will start wrapping up so that we can address the question in the chat box. Perhaps just a round robin. What is one thing our faculty members listening in can start doing right away to strengthen confidentiality and trust in HIV care? Samantha, do you want to start us off?
Sorry, can you the question? Sorry.
It's just kind of like a final note for our listeners. So what is one thing they can do to start strengthening confidentiality and trust in HIV care?
I think there should be more training and a system in place that, when you deal with data, you need to be trained as well. How do you handle it? I understand that the laws say that you need to report infectious diseases, but I think influenza is also an ID, but not many report it. And that is one. But ultimately, I think it has to go for training when it comes to data management, and there should be a tools that make it easy for data users to protect confidentiality. I think that need to be in place. The law can be there, but we need practical tools. So yeah, thank you.
Thank you. Alex?
Can you hear me? Yeah.
Yes.
Yeah, so if I could ask everyone to start with maybe some simple habits. So I think it would be pay attention to small ways we handle information every day. So like, for example, before we send a WhatsApp message or email, even I think for us to prepare the slides. So just pause and ask ourselves, is there any detail here could identify someone living with HIV if this was, beyond my control and forward it to someone else. So if the answer is yes, then remove the detail or anonymize it. So always, I think when you this kind of small practice to keep reminding yourself is a good exercise, it's a good practice that when you look at the information, then you keep reminding yourself. So how you actually safeguard this information, and when your students, when your peers, your friends, when they see how careful you deal with all this little information, so it actually build trust, right? Yeah, so it will build trust that people believe that researchers is not there only mining the data, but we are really trying to working on this, and also not only the small thing, but we are trying to protect the big things like the patient's diagnosis and their stories on all that. So essentially, I think, yeah, that's my thought. Thank you.
Thank you, Alex. And Iskandar?
So from my perspective, I'm just coming from a clinician and probably a more human approach. I think try to imagine ourselves in their shoes and what they are most afraid of. I think generally in Malaysia, a lot of HIV is written in medical notes as RVD or retroviral disease. That is one way of, maybe in a way, patients may feel comfortable in protecting their confidentiality. So it limits that understanding that they have HIV to only healthcare professionals who understand that. It's so important to build that rapport during that initial visit, because that sort of determines their trust in a highly stigmatized and highly in an environment where really they don't trust it very much. So I think that building of rapport with the healthcare professional is so important and will determine what they do next in their subsequent visits. And I think just limit disclosure where only it's medically necessary. Explain the laws and policies of the hospitals if there are specific policies around HIV disclosure. Yeah, so I think that's basically the four things that I would explain to the patient. Yeah.
Thanks, Iskandar. I mean, I think your closing leads very nicely into the question that's in the chat box, which I'm going to read out. It's from Prof. Chan. What is the current advice for care providers who have HIV care provision where patients' care can be more susceptible to the infection? So like dental practitioners. So I guess, why do some patients prefer not to disclose in these settings and their implications?
Okay, can I take that?
Yeah.
I mean, if I was HIV positive, I would not disclose. I mean, I would be very careful who I would disclose to. There's always that risk of balance of what you should be doing, what is the right thing to do, and what you should be doing. And if there is any remote possibility of you facing discrimination and judgment, you would always think twice. In the era of U equals to U, where the person is not at risk of HIV, even through having dental exposures, we're changing the way we advise our patients. Before U equals to U, we always advise them to disclose to healthcare professionals, to other healthcare professionals. It is always good if the patients don't have a problem. It's good to know. It's because it provides more holistic care. But if there is a risk that dentist might then turn that patient away, in the setting where we know undoubtedly and scientifically that the patient is not at risk, then why risk that? So I think it's that balance of risk of the right thing to do and the risk of the patient getting turned away. And U equals to U has changed everything. So and disclosure issues also have changed around HIV in the setting where the patient's on treatment and undetectable.
And can I also add that for things like procedures, universal precaution is meant to be practiced.
Yeah,
so the assumption is that everyone has it, and so the precautions are the same. And often people living with HIV don't want to disclose it because people start double gloving, or they end up getting put at the end of the list for procedures. And all of these are actually discriminatory acts.
Absolutely. And Puli, you may want to add maybe a couple of sentences because you've worked on it as well, about our current guidelines around healthcare workers living with HIV, maybe as a closing as well, because it's very important for people to know that.
Oh, okay. So about 3 or 4 years ago, we actually had a UMHealth breakfast talk, talking about whether healthcare workers with blood-borne viruses should be able to work. And so in the last 3 to 4 years, we've been working with OSHI and with our hospital, and we've managed to get guidance in to allow healthcare workers with blood-borne viruses to work. And they can disclose this to OSHI, and then we report it to the Malaysian Medical Association. So it's okay to disclose, it's okay to work. We just need to make sure that your viral loads remain undetectable throughout this period. So there's a whole guideline for that, which has been approved. So feel free to look it up on our UMMC portal. So this is basically to safeguard our healthcare workers and prevent them from discriminatory practices like being moved to areas which are considered, where they don't do any invasive procedures. And even in the guidance, it spells out what procedures are considered, invasive. But even still, in these situations, they're still allowed to work, so long as their viral loads remain undetectable. Yeah. So on that note, I would like to say thank you to all our panelists and to our listeners. And I would like to wish everyone a happy World AIDS Day. Thank you.
Thank you.
Thanks.
Thank you.
Thank you. Thanks, everyone. Thank you.
Thanks, everyone. Great session. Fantastic moderation as usual, Puli. Thank you.
Thanks, Iskandar. Thanks, Samantha. Thanks, Alex.
Thanks, Alex.
Bye.
Bye-bye.
Thanks, Liana.